Hi everyone and welcome back. In today's video we're going to review the 2015 updated treatment algorithm for neonatal resuscitation, having babies. Now if you're in the field and you get called for someone having a baby, right away you're thinking this.
I don't know nothing about births and babies.
Then you look at your partner and you see him doing this.
Man, game over, man. Game over.
Now, relax, take a deep breath. Statistically, 90% of all childbirths don't require any resuscitation. They're fine. All we basically have to do is not drop them. 10% will require some stimulation to breathe or require some oxygen. Minimal, just oxygen. Only 1% of all deliveries require aggressive resuscitation. So 90% of your births, no big deal. This is a happy occasion. This is an occasion for joy. You're helping to bring a new life into the world. So enjoy it, have fun, and know that 90% of the time, you're going to be just fine. Now, before we dive into the algorithm, let's take a look at the inverted pyramid, because there's some things that we're always going to do. Starting at the top of the pyramid, we see we have drying, suctioning, stimulating the child to breathe. These are all normal things that we all know about that we're going to do right after we deliver a child. And this accounts for most of the care that we're going to be providing. That's 90% of what we're going to be doing. As you go down the pyramid, you see we get into oxygenation, then maybe intubation, then maybe chest compressions, and last drugs. These are very rarely needed. This only counts for 1%. So looking at the top of the algorithm, things we're always going to do in this pyramid, moving down things that we're less likely to need to have to do for this infant. Okay, so let's take a peek at this algorithm. Starting from the very top, first we see antenatal care. Were they doing their prenatal care? Second, team briefing. Get your team together and talk about who's going to be doing what when we deliver this baby. Third, make sure all your gear is prepared. Make sure you have everything prepared, knowing that 90% of the time, you're not going to have to do much. But in EMS and in the hospital, we prepare for things to go south, so make sure all of your equipment is ready. Next, the birth. We're having the baby. Right after that, we're going to ask 3 questions. 1, is this a term gestation? Is the baby done cooking? 2, is the baby crying? Are they moving air? And 3, do we have good tone? That means the baby's active, he's fighting you. He should be fighting you. If the answer is yes to all of those 3 questions, term gestation, breathing, good tone, we're golden. That infant can actually stay with mom while we're doing the rest of our stuff. We don't have to pull that kid away. It doesn't require any resuscitation. So a yes to those 3 questions, baby's going to stay with mom. Now, baby's staying with mom, there's still a few things we need to be doing. We need to dry this baby off. Remember thermal regulation. We do not want this brand newborn getting cold. Now, I did an experiment the other day on myself. Sacrificed myself for science. I woke up, put my robe on, and went outside. Then I took my robe off. Now, I live in the Midwest. It was about 40 degrees. It was really cold outside. So I'm cold. So I put my robe back on, covered myself back up. I was still cold. I needed to provide myself with some warmth, so I walked back inside. That was the first part of the experiment. Second part, I took a shower. Got out of the shower, dried myself off, put my robe back on, and went outside again. I was really cold. I was freezing. Why? Because even after I dried myself off, I was still wet. And through evaporation and convection, I'm freezing now. I'm losing body heat just like that baby. So even after you dry this baby off, they're still wet. They're still cold. It's going to require a couple of times of drying this kid off. And you must provide warmth. It's not enough just to dry the baby off. You have to provide them with warmth. Now in this scenario, we had yes to our first 3 questions so the baby can stay with mom. What's the best way to provide warmth in the back of an ambulance to this brand newborn? What's the warmest thing in the back of the ambulance? Chances are it's mom. She's been working for a while trying to deliver this kid. So you take the infant, dry them off, put them skin to skin with mom, then cover all that up. That will help keep the infant warm, and that's the best way really to apply warmth to this brand newborn in the back of an ambulance. Give him to mom. The baby's now with mom, all covered up. Continued reassessment. We'll suction out secretions if we need to. If you do, start with the mouth first, then the nose, and continually reassess this child. Now, if the answer is no, We're going to continue to provide warmth, so if you're in the back of the ambulance, make sure that heat was cranked up before you ever get there. Clear out the secretions using a bulb syringe, starting with the mouth first, then the nose. Position the airway, make sure this child is able to breathe, and provide additional warmth and stimulation to this child. Keep them warm while you're stimulating them. The best way to stimulate them to breathe, again, is flicking the soles of the feet. That's annoying to a brand newborn. They don't like that. So flick the soles of their feet, get this kid to cry, and open up those lungs. Next is to assess this child's breathing and pulse. If the child only has gasping respirations or is apneic, quickly assess the pulse, and you can do that by palpating the umbilical cord. Another way to assess heart rate is listening to heart tones. Remember, what makes sound are valves opening and closing in that brand new heart. So you can palpate the umbilical cord to check a pulse, or you can listen to the kid's chest and count out that heart rate. We need a heart rate over 100. That's it. There's two magic numbers when it comes to neonatal, over 100 and over 60. In this case, we're looking to make sure that pulse is over 100. If at any time the pulse is less than 100, we're providing oxygen or bagging that child depending on their ventilation status. Now, if this child has gasping respirations, is apneic, or a pulse less than 100, we immediately begin bagging this child. We're going to bag with room air to start. Room air. Attach the ambu bag, begin bagging at a rate of 40 breaths per minute. Then we need to attach an SpO2 monitor. We're going to get a pulse ox. We're going to put it on the child's right hand. We need to start monitoring their pulse oximetry. Additionally, a new recommendation is you can go ahead and throw a 3-lead on this kid, because that will detect the pulse, and if we felt a pulse, we can match that off our 3-lead EKG now and watch this kid's heart rate. That's huge. You want to have one eye on this infant's heart rate the whole time. Now, do we have labored breathing and persistent cyanosis? Now remember, cyanosis is that bluish tint throughout the body. It is not uncommon to have acrocyanosis, which means the child may be pink in the core, but a little cyanotic out in the periphery. That's normal. We'll see that in a lot of births, but we're looking for persistent cyanosis all over the body. A bluish tint all over, coupled with respiratory distress. Now, if you have that, you're immediately going to provide ventilations to this child at a rate of about 40 per minute using an ambu bag. Make sure the child is properly positioned when you're applying these positive pressure ventilations. We're going to monitor their heart rate. We're going to attach an SpO2 monitor, a pulse oximeter, to their right hand and begin assessing their pulse oximetry. Now, looking at our time frame, from the time the infant is born through our initial assessment, our initial steps of drying, stimulating, and assessing the respirations and pulse on this patient, that should take about 1 minute. That's our golden minute. And in that golden minute, we should assess the infant, provide the stuff we always provide, which is warming, suctioning if needed, drying, stimulating, then evaluating their respirations and their tone. Remember those 3 questions in the beginning? We want to get all of that done within the first minute after birth. That is the golden minute. Now, we're providing ventilations to this child now. We're going to reevaluate the heart rate. Is the heart rate above or below 100? If it's below 100, we're going to continue our ventilations. Should the heart rate drop below 60, we're going to begin chest compressions. And those are really our 2 magic numbers. We always want a heart rate above 100 in a newborn. Anytime the heart rate hits 60 or below, we're starting chest compressions. So when you see that on a test, if the heart rate drops below 100, we're bagging and we're providing oxygen. We're oxygenating this kid to get that heart rate over 100. If it falls below 60, we're starting chest compressions immediately. So now we're bagging this child and we're providing chest compressions and we're watching that heart rate. We want to see that heart rate come up. If it doesn't come up, think about an advanced airway. Either tubing this child or maybe an LMA for this child. We get a better airway so we can get better oxygenation into this infant. Now remember, when we first started bagging this infant, we were doing it with room air. Once we're starting chest compressions, we're going to increase that FiO2 straight to 100%. We'll talk about how to measure pulse oximetry here in a moment, but if we're resuscitating this child, that's done with 100% FiO2. So initially, just providing oxygen or bagging, start with room air. If you're doing chest compressions, now we're going to bump it right up to 100% FiO2. Now, if despite ventilation, advanced airway, and chest compressions, we still can't get this kid's heart rate over 60, that's when we have to go to medications. So we're going to have to gain vascular access. Now, if you're in the hospital, you're probably going to use an umbilical catheter, right? Have to gain vascular access, we can use the umbilical cord. That's a great place. You cut the cord, and when you look at the umbilical cord dissected, you're going to see 2 arteries and 1 vein. The vein is bigger than the artery. So where are you putting that catheter? Into the one big vessel you see on the cord. 2 small arteries, 1 big vein, that's where the umbilical line goes. We're going to insert that catheter just into the body. So you can kind of measure up to where the umbilical cord meets the body. We're going to go just past that. We've already flushed our catheter with saline, so what we're going to do is we're going to try to draw back, and as soon as we get blood back, you're golden. That's where you want to be. So really, we're going to insert just into the body, or until we can get a nice blood return back through a flushed umbilical catheter. That's how far you're going to go in. Now, if you're in the field, you're probably not going to use an umbilical catheter. You're probably going to go intraosseous, which is fine. That's perfect. In fact, here's an x-ray of the first IO I ever did. This was on a 1-month infant. And if you take a look, the IO needle I put into the bone was longer than the bone I put it into. Now we have specific IOs in the guns that were designed for little bitty babies, regular sized people, big old enormous sized people. So IO infusion the technology has gotten better, and its use and people's proficiency and their comfort level with IO infusion has gotten much better over the last decade. So go ahead and start. We're going to have to gain vascular access. Start that IO. First drug up, epinephrine, 1 to 10,000, and our dose is 0.01 milligrams per kilogram, or 0.1 mLs per kilogram. Now let's say we have a 4 kilogram kit, right? That means I have to draw up 0.4 mLs of epinephrine and administer that to this infant, which is very hard to do through a regular syringe of 1 to 10,000 because it's measured in 1 ml increments. It's gonna be hard to do. So I can take a 1 cc syringe, put a needle on that, and draw the epinephrine right out of that vial of 1 to 10,000. Hook that up to my tubing and administer the proper dose that way. This way I'm not trying to guess, or I over-administer the epinephrine when I'm using that big 10 cc syringe vial of epinephrine. So measuring this infant using our Brasso tape, we've determined he falls into the 3 to 5 kilogram range. Our first dose of epinephrine is 0.01 milligrams per kilogram, which would be 0.04 milligrams per kilogram, which is the same as 0.1 mLs per kilogram, milliliters. In this case, it's 0.4 mLs. That's what we need to draw up. Now, it's hard using a 1 to 10,000 10 cc vial of epinephrine to administer 0.4 mLs. Now, if you notice, there's a needle in here that when we connect this, that needle's going to puncture into the vial so we can administer our medication. But these are all in 1 ml markings, and it's going to be very difficult to administer 0.4 mLs just using this. So what we're going to do is we're going to attach a syringe, a 1 cc syringe with a needle, and draw it up into a 1 cc syringe. Now, I've added food coloring to this vial of epinephrine so we can see when I draw it up. I'm going to take the needle, go right into the epinephrine, and I'm going to draw up my 0.4 mLs. I'm going to leave my syringe attached, come over to my port, attach it, I clamp off here, administer my medication, and we can see that I've administered it from the syringe into the tubing, but I needed to get it from the tubing to the heart. Now I could use the same syringe. I'm going to clamp the tubing distal on the patient side and then draw up, using the same syringe, fluid from the IV bag. Then I pinch the tubing on the bag side, and I could push that flush in and push that medication into the patient using the same syringe, and then repeat as necessary. But this way I could use the same syringe I administered the medication with to provide my post-medication fluid bolus to push that drug to the heart. The use of pulse oximetry. We use this all the time in adults. We can also use it in the newborn to see, is this infant really moving from fetal to adult circulation? Take your pulse oximeter, place it on the newborn's right hand. Then we're going to use this gauge to see, is the newborn's oxygen saturation improving over time? And the way I remember it is I start at minute number 1 at 60%. And it should go up 5% every minute. So, SpO2 at 1 minute, 60. Next minute, 65, 70, 75, 80. So at 5 minutes, this newborn saturation should be between 80 and 85%. Over the course of the next 5 minutes, we'd like to see their saturations go from 85 to 95%. So again, use pulse oximetry. This should measure how well the oxygen saturation in this newborn is improving over time. Start at 1 minute, check the first 5 minutes, should go from 60% to at least 85% over the first 5 minutes, and then from 85 to 95 over the next 5 minutes. Now, does anybody notice what's missing in this algorithm? Something important that might pop up that just doesn't appear? Like when to cut the umbilical cord? Yeah, it's not in the algorithm, so let's talk about that. One of the new 2015 recommendations is called delayed cord clamping. And what that means is in a normal delivery where we don't require resuscitation, we can wait. We can take our time. We can give it 30 seconds to a minute before we clamp that cord. Now, I was flying with a NICU nurse over the weekend, and we were talking about this delayed cord clamping, and she actually called one of her neonatal cardiologist friends and asked him about this. And what he said makes sense. Right after this child is born, right, they're not breathing yet. They have to start breathing, open up the lungs, get that pulmonary vascular system filled up, start moving oxygen throughout the body. But before that, they're still attached through the umbilical cord to mom. So mom almost becomes kind of like ECMO for the first few moments of life. The baby is still receiving oxygen and nutrients through that umbilical cord, which is attached to mom. And we want to keep that going. We found that early cord clamping isn't all that great for the kid. We want to make sure they get all the blood volume, they stay oxygenated until the baby has started crying, he's opened up those lungs, and now the infant is oxygenating himself. Then we can go ahead and cut that umbilical cord. Now, when would we want to clamp and cut the cord right away? Let's say we deliver this newborn, there's no activity, they're not breathing, and we need to begin resuscitation quickly. That's when we'll go ahead and clamp and cut the cord because we need to start working that infant. And if we don't clamp the cord right away, that could delay our ability to begin positive pressure ventilations.